Thank you. Um, Welcome everybody to the Avon Wiltshire Mental Health Partnership Trust Annual General Meeting. This meeting is being recorded, and there was a little note to say that if anybody, particularly those online, if you don't want to be in the recording, which will appear on the website, can you just turn your cameras off? Thank you. In terms of this meeting, the purpose is for us as a board to formally receive the annual report and accounts from last year. They were published online in June, but this is an opportunity for the board to formally receive them. The other things we will be doing during this meeting, we will take a strategic or share with you a strategic overview of the year 24-25. We will receive the financial performance report of 24-25. We'll look at the quality account, and then we're going to just touch upon the 10-year plan, which was published earlier this year. And there are 3 shifts in the 10-year plan, and we will have presentations from our organisation in relation to the hospital to community, the treatment to prevention aspects, and the analogue to digital aspects. We will then be open for questions from the public or from people in the room before we close the meeting. So in order to start in relation to the welcome, my name is Jan Baptist Grant and I'm the Vice Chair of the Trust. I am here in person because our Chair, Paul Miller, who is online, is unable to be with us today. I'm going to just pop round the table and perhaps ask members of the board that are here present just to introduce themselves to the audience, please. Can I start with Ela?
Good morning, everybody. My name is Ela Bartlett-Sen, and I'm a non-executive director for the Trust, and I chair the Quality and Safety Committee.
Thank you, Dawn.
Morning all, Brian Stables, non-executive director, senior independent director and chair of our Audit and Risk Committee.
Morning everybody, my name is Sarah Constantine, I'm the Chief Medical Officer, and I also will be representing Dominic Hardesty, our Chief Executive today, who unfortunately is unwell.
Thank you.
Good morning everyone, I'm Martin Ward, I'm the Chief Transformation, Estates and Digital Officer at the Trust.
Good morning everyone, I'm Paul Olomolai and I'm a non-executive director of the AWP and chair of the Mental Health Legislation Committee.
Morning everybody, I'm Jane Williams. I'm currently acting Deputy Director of Finance.
Good morning, my name is Derek Hammond and I'm the Deputy Chief Operating Officer, deputising for Matthew Page, the Chief Operating Officer.
Hi, and I'm Donna Cairns. I'm the Company Secretary.
Thank you, Donna. And online, Paul Miller, would you like to introduce yourself, please?
Hello, my name's Paul Miller. I'm really disappointed not to be with you today, but I'm going through some cancer treatment, and my prize for not being with you is I have a chemotherapy session this afternoon. So I think I would rather be with you in the room today.
Thank you, Paul. Can I ask Paul Coombs to introduce himself, please?
Yeah, morning everyone. Again, apologies I can't be there in person. I'm Paul Coombs. I'm an Associate Non-Executive Director.
Thank you, Paul. And Christine, could you introduce yourself, please?
Good morning, I'm Christine Capocco. I am the Deputy Chief Nursing Officer at AWP.
Thank you, Christine. We have apologies from the following. Julian Feasby, the Chief People Officer, Matthew Page, Sarah Jones, Paul Spencer, Pete Tilley, Emma Wharton-Love, and Dominic Hardesty, the Chief Executive. Okay, can we then go through the minutes of the meeting, the last AGM meeting, which was held on the 19th of September 2024. don't know if we've got them, we haven't got them on screen, have we?
If you just want to accept them as a correct record, we can.
Okay. Have my colleagues had an opportunity to see the minutes of the last meeting?
Yes.
Yeah, and are you happy to accept them as correct?
Yes.
Fine, thank you. Okay, so I did say that the purpose, one of the main purposes of this meeting was to receive the annual report and accounts for 2024. Those accounts were published online. And as I said, they're on the website for the public to be able to access them. We also have a code which will be shown up, I think, on one of the presentations a little bit later, where the public again can access a copy of the annual report and the accounts. So our purpose is to formally receive those as the board. And so I'm going to look to my board members to ask whether you are happy to receive the accounts and the annual report for 2024.
Yes.
Yeah.
Yes.
Okay, thank you. And online, Paul, I can see you have too. Thank you. I'm going now then, sorry, my voice is gone. I'm going now to move on to offer you a strategic overview of the year in perspective. That year being from 1st of April 2024 to the 31st of March 2025, so our last financial year. And I'm going to hand over to Sarah Constantine, who is deputising for Dominic Hardesty, to share with you some of the highlights from last year. Thank you, Sarah.
Thank you, Chair. So got some slides.
I don't know what's happened to the slides, bear with me.
Whilst you're getting the slides up, I'll just remind everybody about just the overview of us as an organisation. Just thinking about our vision and our values. So our vision is to deliver high quality, compassionate care for people living with mental illness, learning disabilities and autism. And that underpinning that, we have a set of values which we call our pride values. That is passion, respect, integrity, diversity and excellence. And our aims are to be a great place to work, to provide outstanding care, deliver sustainable, I can't speak either, sustainable services and work together in partnership. And we have a published strategy called Together We Are AWP. And you'll see on the slides that we have a link to that. So I'm just going to give a broad overview of what was a very, very busy year for us and for the NHS, just looking at some key areas to highlight. So next slide, thank you. So looking at our staff survey, because as I've said, our first aim is about being a great place to work. And we've had some real positive results that the number of staff who would recommend AWP as a place to work is at its highest level for the past 10 years. More staff have said that the organisation is compassionate and inclusive. We've seen an increasing number of staff who feel recognised and rewarded, and our staff morale scores are above the national average for similar trusts. Our biggest improvement area was seen in the organisation's approach to learning and about flexible working opportunities. And we continue to roll out our Great Place to Work programme, which is that cultural programme, that overview. Having said that, it's very positive, but we still recognise that we have a lot more work to do. So moving on, I'll just highlight some of specific areas. So in June 2024, we had a CQC well-led inspection. It looked at trust-wide leadership, governance, management, culture, and it included interviews with our senior leaders, with other staff groups, patients and partners. And the report was published in May 2025. So that obviously is a long time between inspection and publication. And it gave us a well-led rating of requires improvement, with several areas highlighted for improvement. And those include safeguarding processes and governance, an experience of closed culture in some services. People with lived experience didn't always feel included in strategic decision making, and we haven't ensured freedom to speak up processes were as effective as they could be. If I move on to our response to that, so a downside of the delay in publication was that there was a delay in publication, but on the other hand, we continued to make improvements within that time. So if we can move to the response, we'd already put a lot of work in train, and you can see, as I said before about the staff survey, that we've had an increased number of staff who see us as inclusive and compassionate, and that piece about recommending us as a place to work. We've continued to, we've done a cultural review, particularly within secure services, and that is showing signs of improvement. We have been embedding our co-produced working together strategy. We've had an Equality, Diversity and Inclusion Board Summit, which was supported by our EDI staff network leads. So they came in, they've been leading that programme with us to deliver the work that we need with the board. We've got board level EDI pledges and objectives, and we are holding ourselves to account to those with regular reviews. And we're now implementing the National Patient and Carer Race Equality Framework, working to reduce health inequalities. And we have regular reviews of that, and I am the exec lead for that programme. In addition to the well-led response, our acute adult mental health wards and community mental health services have now been rated good by the CQC. On our acute and intensive care psychiatric units, the CQC commented that we've made significant improvements since the last inspection, and as they said, also for our community health services. So patients are feeling more listened to, they feel that staff are compassionate and are supporting, but also staff feel more valued and able to raise concerns. So overall, with the response to CQC, we'll continue to have a real focus on that, particularly working through our cultural programmes, and we continue to have the board focus on those aspects. Lots and lots of other highlights for 24-25. We won a National Sustainable Organisation Award. We reduced temporary staffing by 58%. We're hugely proud of the work that's we're undertaking for our new learning disability and autism unit, the Kingfisher, and we are working with regional colleagues. We are already looking at recruitment. We're bringing the team together and looking at that clinical pathway. We have a new men's crisis house, which opened in partnership with Rethink. We've achieved a Gold Standard Tide Award, and we won awards in the Integrated Personalised Care Awards in 2024. So that was for Integrated Access Partnership, Nature-Based Practice, and the introduction of Your Team, Your Conversation, Your Plan, which is replacing CPA to be a very much co-produced and working with service users to produce their own care and safety plans. Further highlights is that the Integrated Access Partnership was shortlisted for an award at the HCSJ Patient Safety Awards. Our MINT teams, so that's our community mental health teams in BNSSG, have been shortlisted for a National HSJ Award. And we've got the launch of our new VCSE partnership, which is delivering community services in BSW. And for those of you that are with us this afternoon, we will be focusing on our work with VCSE. And we were re-accredited as Veterans Aware. So I'll bring this section to a close, just looking at some of the challenges that we face moving forwards. It's acknowledged that we have continued challenges about patient flow, which leads to capacity issues. And we still now see some patients being admitted to beds out of area, because we also have a high demand in some services and higher levels of acuity. Working with the new Director of Transformation, Estates and Digital, we are looking at transformation projects, both within our divisions and throughout the organisation, to look at patient flow so that we can bring patient care closer to home to improve patient experience. We continue to be challenged around CAMHS access rates. We are continuing to monitor cultural issues within secure services. And I think it would be unfair not to acknowledge that we have challenging financial landscape, including the requirement to reduce corporate support costs. And as ever in the NHS, recruitment does remain a challenge, although we're working incredibly hard in that area. So I'll bring this section to a close, really, just to thank, on behalf of the board, all of the staff that work for AWP and with AWP and our partnerships as well, for the amount of work that people are doing to really bring great clinical care to the people that we serve. And just thank you to everybody, and knowing that we will all work in partnership moving forward to continue to improve the care that we provide. Thank you, Chair.
Thank you, Sue. Any brief questions before we move on? No? I'll leave the questions until the end. Okay. So can I move on then to invite Jane Williams, our interim Deputy Chief Finance Officer, what was his name, to share with us, give us an overview of our financial position from 24-25, and also the financial outlook for the trust moving forward, please.
Thank you, Jan. Just hoping that my colleague could switch over to doing slides, but if not, I'll put them back up again.
Thank you.
I'll start. As we know, we've accepted the annual accounts and the annual report for 24-25, and I'd just like to give a brief overview of what they displayed, and also, as Jan mentioned, to give us an overview of what 25 looks like. So as a financial NHS financial organisation, we have a number of statutory duties that we have to adhere to, and I'm very pleased to say that we met all of those during 24-25. So as on the slides, I think that is that we delivered a break-even revenue financial position, which was in line with the plan that we set for the year. We achieved our capital resource limit, which means that we spent the money we received from capital projects on the items that we committed to. We actually exceeded our cash target, so we had more cash in the bank from the end of the year than we planned, which is a very good position to be in. We maintained an excellent performance against our Better Payment Practice Code, which means we pay at least 90%, 95% sorry, of our suppliers within the 48 terms that doesn't break practice. And within that, we also maintain strong financial governance practices, which encompass all of those things we managed to achieve over the year. So our auditors audited our accounts for the year 24-25. Grant Thornton are our auditors. They reviewed our accounts and gave us an unqualified opinion, which means that our financial records and statements appropriately presented our position for the year and backed up all of those key statutory requirements that I've just mentioned. In addition, our value for money opinion from our auditors concluded that we had no significant improvement recommendations required. That is an improvement on the previous year, and that is because they recognise that we have a medium-term financial plan which shows our trajectory for the next few years, even though it's recognised that we still do have an underlying deficit within the trust. So just a few key headlines from 24-25. Our total staff costs were 312 million. Within that, we did have agency costs of 21 million, but that was against a plan of 26 million. So that was an improvement against the plan and a significant improvement on the year before. So we are headed on a very good trajectory, although still understanding we do have a long way to go. We also achieved savings of £9 million, which is against a plan of 9.7 million, and represented 93% delivery, which is a very good place for us to have been in during the year, and some key themes did deliver for us, which we are very glad to have been part of. The break-even position was achieved, as I've mentioned, and we retained our single oversight framework rating of. So the agency position that I mentioned on the previous slide, we actually had a reduction of £15 million of agency year on year, which is a significant achievement for the trust. We had non-recurrent system funding of £12 million, which is helping to balance our bottom line. So although we had a break even, virtually zero, within that we had £12 million of funding from the ICB, which helped us. Within our capital funding, we did receive a significant amount of funding from state, but we do know that we still have a long way to go in terms of improving what we can provide to our service units and to us. Out of area costs, although they were significantly improved during the year and helped us to achieve the savings that I mentioned, we do still recognise that we have the rest of the to go on. So within our capital programme, we had £27 million. So as already mentioned, the Kingfisher unit, which was a significant portion of that. So we spent £23.2 million on improving our environment, of which the Kingfisher unit was a substantial amount of that. We also spent £3.1 million on improving our digital infrastructure. We were very fortunate to have received £22.6 million of that £27 million as public dividend capital, which we received from the Department of Health. The financial outlook for the trust during 25-26 will be challenging, as it is across the wider NHS body. So I've noted that we exited the financial year with an £11 million underlying deficit for 24-25, and part of our medium-term financial plan is that we need to look to remove that underlying deficit over the next 3 financial years. We have received non-recurrent deficits for 25-26 of £10.1 million. That replaces the £12 million that we received in 24-25, and that has helped us to provide a balanced plan through the year, though noting that there is a significant challenge because in order to achieve that break-even position, we need to achieve £11.3 million of savings. Trust is looking to reduce its workforce position with regard to agency and the trajectory for that. Although this shift won't be as big during 25-26, we are still seeing the trajectory which is on the downturn during 25-26. So as already mentioned, we do still have continued challenges with supply of staff. We do still use agency and bank where we need to, but there are significant work streams across the trust working to improve that so that we can improve not only the financial aspect of that, but also the quality of care to our service users. We're all aware that the demand for mental health services continues to grow, and that does put pressure on operation services, but we're all working together to aim to produce the right operational, quality and financial output. We continue to bid for funding for our estate, and we are also spending a significant amount of money on our estate through public dividend capital for the year, and we will obviously be able to track that as we move through the rest of the year.
Jane, we will, as I said, take questions at the end. I'd like to invite Natasha Bryant now, who is going to talk to us about suicide prevention. She's our suicide prevention lead, and she's going to talk to us about the safety assessments that we undertake. This was featured as part of our quality account, and again, as I said, it's published on the website. So Natasha, who's online, over to you.
Thank you, Jen. Can you hear me okay?
Yes, we're fine, thank you.
Excellent, thank you. I've already been introduced. My name's Tash and I'm the lead nurse for suicide prevention here in AWP. And I'm here this morning to present our quality improvement project on transforming our approach to safety assessment and formulation. This work represents a significant shift from managing risk to promoting safety, and the work has been rooted in compassion, evidence and lived experience. So every day, 17 people die by suicide in the UK, and of those, around 5 will be in contact with mental health services, and the majority of which will have been assessed as at low or no risk of suicide at the last contact. This highlights a fundamental flaw in traditional risk assessment tools. Suicidal impulses are dynamic and unpredictable, and our systems must reflect that reality. The impact of suicide is devastating. Every life lost is an individual tragedy, and for families and loved ones, the grief is unimaginable and enduring. At AWP, we are committed to doing everything we can to save lives. And this means not only improving clinical practice, but also transforming the culture around safety and support. Next slide, please. Thank you. So this slide shows the national momentum that has driven change in how we assess and respond to suicide risk. Starting in 2021, the formation of a national network signalled growing concern about the limitations of traditional risk assessments. By 2022, analysis of prevention of future death reports and a letter from the chief coroner highlighted that flawed suicide prediction was a national and recurring issue. NICE guidance NG 225, which was published in September 2022, was a turning point. It clearly stated that risk assessment tools and global risk stratification should not be used to predict suicide or to determine care. National leads from NHS England followed with letters urging trusts to adopt the guidance. AWP responded quickly and proactively. We formed a project group and we made interim changes to our system. We began developing a new model aligned with national strategy, and while some other trusts were still exploring options, we made measured and interim changes as fast as we possibly could. By April 2024, we had fully launched our new approach to safety assessment and formulation. We didn't wait for change, our clinicians helped shape it. That put us in a position to contribute our learning to the formation of new national guidance, which was Staying Safe from Suicide and published in April 2025. It also meant that I was able to share the views of AWP service users and clinicians at a national level, leading to this new language of safety being adopted into national guidance. Next slide, please. Okay, so these are some of the highlights from the NICE guidelines, which are very, very clear. Risk assessment tools and global risk stratification should not be used to predict suicide or to determine care. Instead, assessments must focus on individual needs and safety. This guidance was a cornerstone of our project, and it helped us reframe our approach from prediction to prevention and from categorisation to collaboration. Next slide, please. Okay, so when NG 225 was published at the end of 2022, we began by engaging with clinicians and, most importantly, people with lived experience. They told us that the tick boxes felt meaningless, that the old risk assessment process left people feeling unheard, judged and labelled. People told us that the very term risk assessment felt stigmatising and uncaring. Our lived experience partners reminded us we're people, not just a risk to be managed. Our previous system had over 80 tick boxes and multiple stratification layers, and there was little room for personalised narrative. The evidence was persuasive and the voices of lived experience were powerful. It was time for change. Next slide, please. So this is going to be a whistle-stop tour of what is a good couple of years of work from a number of people here. But our change journey began with listening. We engaged with staff, service users and stakeholders. We then reviewed national strategies, evidence and audits. We began planning with board support and we aligned with our care planning transformation programme. We co-produced a new model with service users, families and clinicians, and we tested that in diverse settings and it was communicated widely. Next slide, please. Okay, so these are the principles of our new approach from which everything else was built upon. So those principles are the need for a focus on individual needs and safety contexts, avoidance of global risk stratification, the use of clinical conversations that are rooted in compassion and curiosity, recognition that safety isn't a number and safety isn't a checklist, and involvement of families and carers is key. This is about seeing the whole person in their wider context, not just their risk profile. Next slide, please. Okay, so this is some of the qualitative feedback that we have received from service users, from staff and other professionals. So service users have said that they've felt empowered, clinicians feel more connected, ward managers have reported improved collaboration. And one service user said, "It's the first time it feels like we are planning for my safety rather than predicting my failure." That's the real impact of this change. It's not just procedural, it's deeply personal. Next slide, please. So our inpatient audit data supports the qualitative feedback. Compliance across key indicators is high, from timely assessments to the involvement of carers and multidisciplinary communication, but it also highlights areas for further improvement. As of October 2025, so next month, we're going to be launching a new combined personal wellbeing plan and safety assessment quality audit across all AWP services in scope, and that will then be used to inform ongoing cycles of review and improvement. And just finally, from my own perspective as the project lead, I just wanted to say that this has been about so much more than compliance. It's been about people. It's been about their families, and it's been about compassion, connection and care. Thank you.
Thank you, Sasha. As I mentioned earlier, the next three presentations are going to share with you our plan for the way that we are moving to deliver the newly published 10-year plan. There are three strategic shifts in the plan: moving from hospital to community, sickness to prevention, analog to digital. And so I'm inviting, or we as a board are inviting, representatives from across the organisation to share with us our approach. And can I first of all invite Sam Mongan, Alice Peake and Andy Warren to share with us the move from hospital to community and the partnerships that we're forging in BSW.
Should we go up?
Yes, please.
Morning all. We've got Alice here today. We haven't got Andy with us in the second step. We were very privileged to have a partnership organisation, Second Step, in the room with us today who are supporting part of this work. I'm Sam Mongan. I'm Head of Transformation for the Baines, Swindon and Wiltshire Division in AWP. And
I'm Alice Pike. I'm the Head of New Business for Second Step.
Lovely. So in some ways, mental health services are probably ahead of the game nationally in terms of the shift from hospital to community. We've had the community mental health framework around mental health services for, I think, 6 years now. So there's been a real focus over that time in thinking about how do we increase access and support for people with their mental health at a community level and not waiting for people to hit crisis point and needing a hospital intervention. And today we're here to talk about the partnership that we have in the BSW division that's working across AWP and PCSU organisations to do that. Alison.
Thanks. So we, to kind of orientate you, the Mental Health and Wellbeing Partnership are for VCSE organisations. Elaborate is the second step. And we've come together and we've been successfully delivering the community mental health services since the 1st of April. And just at kind of a high level, that includes the Place of Calm in Wiltshire, includes 3 crisis houses, the Access Community Mental Health Services across Bates, Swindon, Wiltshire, and the intensive outreach centres across Bates, Swindon, and Wiltshire. And although we were bidding for and won a contract that was aimed at the voluntary sector alone, the focus was always about how do we work collaboratively with AWP, with Oxford Health, about delivering integrated services for the population that need those. So one of the early pieces of work that we worked on collaboratively across all of our organisations and with the ICB was to bring together a mix of exec and senior leaders and others to develop a shared vision and a set of guiding principles, the vision's up here, around how we were going to integrate and work together. And that kind of then drives down throughout all of the work that sits underneath that, which has been incredibly helpful. And I think part of that that has informed the work that we're going to talk about today, which is very much about the access work stream, which is around how we look at an integrated pathway for the clients that are coming through the primary care liaison services that AWP run, but also through these voluntary services. How do we make sure we're meeting the right population, those people who are in the gap? What do we do to integrate that work and change that going forwards?
The next slide, a little bit around why this is important. So we spent a lot of time listening to people who use services across NHS and voluntary sector organisations in terms of supporting their mental health. And there are some themes that have come up around that we need to respond to. This isn't a judgment on any one service or organisation. This is people's real lived experience of what they've experienced within their communities. So people struggle to find early support to prevent them getting into crisis. So they struggle to know where to go to for help, and they struggle to, they may have to wait some time before they access that as well. They feel that services that they work with are sort of implemented, so they can spend a lot of their time having to repeat their stories and talk to people about their needs, without those services actually talking to each other and wrapping around other persons as well. People often feel that they have to sort of jump through hoops or demonstrate a level of need to hit a threshold to be able to access services, and feel that the barriers are put in their way to be able to. So rather than thinking about people's needs and looking at them as a person, we think about what the service offers, and therefore try and get people to see whether they fit with those or not. And that creates sort of difficulties then in getting the appropriate care for people. So often the answer is, I'm sorry, we don't have a service that can support you with your needs. That's the end of the conversation, rather than thinking about what collectively do we have in our community that can support you with your mental health. And finally, we also see an inequity of access, experience and outcomes across different groups as well. So we know for certain groups and demographics and areas, people struggle sometimes to access services in the first place, can have very different experience of their services when they access them, and often have different outcomes in terms of the impact that they have on their mental health as well. So our aim is to create an integrated service between AWP and the voluntary sector organisations that really is inclusive, that's person-centred and trauma-informed, so we understand people and see the person first rather than the service offer. And we're focusing on the things that will have an impact on their mental health and help them with their recovery as well. So what are we trying to achieve there? So what will the future look like moving on to the next step? So this is what we want to achieve between our organisations. So our staff, no matter what organisation they're working with, work seamlessly together to join up people's care. We've already got tools that we've talked about already today in terms of personal wellbeing plans, your team, your conversation, your plan that will support us to be able to do that. We want our teams to join up and do that as well. We want to move from a no, this isn't right to you in terms of referrals, bouncing back to referrers, to taking people in and working out what the best place to support people is. That won't always be AWP services and NHS services. Often there's a better offer within the community that can support people with their needs, and often it's more timely offer as well. So our job is to find those, make them work for people as well. So that will create a faster access for people, both in terms of those people who require that community support, but also for those people who do require as a higher level secondary care services, because we will not be having to sort of put everyone through an assessment for those services, and therefore they can be more responsive to those people who really need them as well. Really importantly, it has to be about making sure that people feel listened to within this. So moving away from that trying to fit people into boxes, to really making sure we understand people's story, they're not repeating it, and that the services themselves are trauma informed and culturally inclusive, so we see the person first. And the overall aim of this is to actually improve people's mental health as well. So shifting from the thinking about what we look at traditionally, often in the NHS around sort of waiting time and activity targets, to really thinking about the outcomes that we're achieving for people. So are we measuring the thing that's important to the people in terms of their mental health as well? So those are the elements that we're using collectively to redesign the services that we have in BSW. So moving on to the next slides. So this is I was going to talk about how we do.
So this has been, it's all of this describes me kind of that partnership working element and bringing the best out of everybody and working to strengthen the organisation. So that grounding with the vision and principles that we've developed at all levels of the organisation is really drilling down and supporting that. So this work stream that we're delivering around planning these integrated pathway of services is very much co-planned, co-delivered, resourcing it between ourselves. We're thinking about how we make that work. And I think that piece filters through. So we're bringing in expertise from different parts of our organisations and different disciplines across the partnership and across both AWP and others. We're using a quality improvement approach that works with the trust, that's familiar to people, and bringing in skills from other organisations or other aspects of our organisations, and really looking at both. In the long term, we want this integrated services. We've got a service plan and a set of collaborative workshops that we're working towards to deliver that. But we're also really aware we're delivering services here and now. And how do we develop these things in a way that we can see benefit? So where things can be lifted off the shelf and started to use that, we use the relationships we're developing to secure local improvements in each of the areas, each of the teams. But we'll design the new parts of the system in a sequenced way so that we can roll out the elements as they're ready. We can test and learn before they necessarily go to all geographies and try and secure that benefit in a short term. So for example, around how we screen and decide who should be seen by which professional first with the maximum impact, and how we get them back into the right parts of the system. We're really proud of how the collaborative co-design process is working with people with lived experience so far. So we've got 2 people with direct lived experience and 1 person who's got experience as a carer, who are involved in all of our workshops. They've brought a huge amount of benefit. They've got a specific facilitator there to support them in the process. And we're using a toolkit called Safe Spaces Toolkit that's been developed by people with lived experience in the second step around how to make this kind of process as inclusive and as valuable for them and enable them to contribute as many as they can. So that looks different for different workshops to make sure that they have an opportunity to feed in regardless of where they're at in that moment. And that's been really impactful and has led to changes in our thinking and how we work already, and really positive feedback from those individuals. And I think that will really benefit the end products because they have that co-design process. And throughout, we've also got shared governance. So the work of this group will report into the Integrated Community Programme Board that's co-chaired and through to AWP and shared system governance structures, but it also feeds into the partnership board for the Mental Health and Wellbeing Partnership. And there's people with lived experience with both of those boards, so that's kind of that sits throughout the work. And we have plans, and we will be delivering much more integrated work in this design phase with the wider voluntary sector, with planned care homes, GPs, and with local authorities as we get to the point of being able to do that. And that will really focus into the pathways into and out of services and across making sure people get the best system access for what they need in that moment.
Next slide. So just wanted to finish really, I guess, around thinking about the impact of this, which, because as Alice said, there are changes that have been made already that are already having a positive impact on people's lives and experience as well. So we now have over 3,000 additional people within the BSW system who are supported through the joint approach that we now have in place and we continue to improve. So that's 3,000 people who previously we wouldn't have had necessarily the right offer within the NHS for, and certainly would have had a joined up approach in terms of their care as well, that we're now supporting jointly. And we expect that to grow over the coming years as well. The work we're doing means that we're able to meet the national targets that we have around people waiting a maximum of 4 weeks between their referral and having an assessment of their needs. And we couldn't do that if we didn't have the partnership that we have with our voluntary sector organisations to make sure we're identifying the right support for people as early in the process as possible. And finally, another piece of the jigsaw really that the voluntary sector is starting to be a part of it as well, is focusing on a joined up approach that's not just about people's mental health, but the physical health elements of people's care as well, which we know is really crucial for people, particularly with severe mental illness. And we've had real success in our area of increasing the amount of people who are receiving their annual physical health check, which means we can understand both their physical health needs alongside their mental health needs. And our voluntary sector partners are also supporting us with increasing that across all of our communities as well. So thank you very much for letting us share where we are with you, and we'll be looking forward to sharing maybe where we've got to again in 12 months and further successes we've had in DSW.
Thank you, Sam. Ask Jane Anderson, Victoria Humphrey and Elle Woods to share with us the innovative partnership approach that we're taking to non-custodial criminal justice services in treatment to prevention of the NHS plan.
Hi. Could we have slide 1, please, sir? Let's just introduce ourselves. I'm Jane Anderson. I'm the Portfolio Manager for Offender Health Services within AWP.
Yeah, afternoon everyone. I'm Vic Humphrey. I'm a Community Service Manager working within Offender Health.
I'm Elle Woods. I'm the Female Pathways Lead with the Integrated Non-Custodial Service, which we're going to be focusing on today.
Slide 2, please. So in April this year, we went live with the Integrated Non-Custodial Services. This was an innovative piece of commissioning by NHS England across the whole of the South West, divided into 5 lots, but with very much the message that providers should work collegiately across the South West, join together to ensure that there are linked pathways. AWP partnered with 4 other agencies in our local area, bringing together the experts in all the different aspects of non-custodial services under our umbrella of governance, support, structure. And we were successful in Avon and Somerset and Wiltshire, which were the 2 lots we bid for. Thank you. Slide 3. So our partnership is the Nelson Trust, the experts in women's services and criminal justice, a national voice, and they provide our women's pathway across all aspects of integrated non-custodial services. Turning Point, our partners in providing mental health treatment requirements. They've been doing it since the pilot and are nationally recognised for their work in that. DHI, also delivering mental health treatment requirements using a slightly different model to encounter the demographics specific to the Bristol and Baines area. And Somerset Foundation Trust, who partner with us to provide across the whole patch of Avon and Somerset. Slide 4.
So you may be asking what integrated non-custodial services is, INCS for short. So this is an umbrella term for 4 sub-services within that umbrella. So the first one being liaison and diversion. So some of you may know what that service does, but this is initially the kind of third point of contact for anybody who's come into contact with criminal justice. We're based in both police stations and courts across the geographical footprint of both Avon and Somerset and Wiltshire. We identify, we assess, we then offer support. That could be in the way of either signposting, self-help, brief intervention there and then on the spot, onward referral to secondary services, third sector services, or diversion where necessary into events, basically, if there are none. The second service within our framework is the mental health treatment requirement. So this element is a disposal option for our magistrates, our judiciary, and this is primarily focused at those offending where mental health, the primary mental health concern has been part of their offending behaviour. This includes 12 sessions, interventions whereby it's probably best described as talking therapies. So obviously they did their 12 sessions and that's the end of their community acceptance. We then have our Reconnect service, and this is the service that reaches into our prisons. And the idea behind this is that we can reintegrate prisoners back out into the community to link in with their healthcare needs. So we work with those individuals 12 weeks before release and up to 6 months post-release. Getting them to their appointments, linking them back up to GPs, dentists, those kinds of things. So it has to be health related. Within the Avon and Somerset area, we also have our drug education programme, Think Speed Awareness. If you've been caught in possession with a substance on you for the first time, you're off with this course.
And uniquely for us, we are an all-age service, so from the age of criminal responsibility, which is age 10, right the way through. And also we're an all vulnerability service. This is not specifically about mental health. It's all vulnerabilities are signposted and access points. Next slide, please.
It's not me, it's somebody else. I can tell it.
So obviously the benefits of that, so the benefits they're clear to see there. Obviously, reduces reoffending, we hope. Improves health outcomes for individuals. And I guess similar to your presentation, we're working with really disadvantaged groups of people that aren't those that go knock on their GP's door. So it's really important to try and improve those outcomes for those individuals. We all know community-based treatments are far cheaper than hospital or prisons, for example. And obviously those people that are healthy and well, we hope will obey the law and not get into trouble with them. Those are things.
Next slide.
So lived experience involvement is absolutely fundamental to everything that we do. So kind of at all levels, even from the very early stages of commissioning this contract, lived experience voices were included in those conversations. The service specification was developed with contribution from lived experience. But I think as a service, our approach to lived experience is something we're really proud of. So last year we were granted the Gold Award on the Lived Experience Charter in recognition of that. It's something we've always prioritised. So the focus of what we do is very much on co-production and collaboration rather than simply kind of consulting people with lived experience. We want them to be actively involved in the development and the delivery of the service. I think particularly in criminal justice populations, most people who've come into contact with the criminal justice service will have experienced stigma, marginalisation. So I think seeing someone who's had similar experiences to themselves in a position where they've actually kind of come out the other side and they're involved in delivering the service is incredibly powerful. You can't even underestimate how much that means to people. But I think as well, people with that experience are, for the most part, best placed to understand what works, what the barriers might be, what might we do differently. So it's something we're continuing to develop. It's we've had this recognition, but we're continuing to build as part of this new contract through creation of Peer Academy, for example, and just ensuring that we've got that lived experience perspective embedded in absolutely everything that we do.
The partnership board is chaired by someone with lived experience, not by us.
Yeah. You have the next slide. So we've got two colleagues with their own lived experience. So if you could hit play on those, we'll hear from Kelly and Sam.
What is your involvement in improving the delivery of the service?
So I started my journey as a peer mentor with advice, custody and courts. I have lived experience. I've personally experienced drug and alcohol, mental health, and I've been in addiction for 28 years of my life. This included homelessness, numerous prison sentences, custody and courts. I went through training with the peer support, and I now support and nurture the new volunteers that are coming through, and I try to help bring out their transferable skills with the experience that I had myself. I also support service users through the court process. I've been on the interview panel. I have, so within the interview panel, we interview prospective applicants applying for jobs within AWP. I have nurtured myself, and my self-esteem and self-worth has massively improved. I've attended training, handled difficult situations, and 3 days ago I started my new job role with Reconnect as a recovery worker.
Second video, please.
My name's Sam Till, and I'm a support time and recovery worker with the Reconnect service at HMP Bristol. Lived experience within the criminal justice system, within substance misuse, and now I actually get to work in a prison supporting people when they leave.
What is your involvement in improving the delivery of the service?
So since before I got this role, I used to take part in the quality and standards meetings. I've helped to facilitate training to staff. I've sat on many interview panels. Was and still a member of the Lived Experience Hub. We put on a fantastic celebration event recently, and we created a really good jargon buster.
Can you give an example of something that you've been involved in that has been an improvement for the service and or yourself?
I'd say the Lived Experience Hub is probably the best one. Various people come together from all across Specialised, and we talk about what's going good and what needs to be improved, and then we come up with projects to get that stuff improved. The jargon buster was something that come out of that, and it's a really great document which can be used by service users and people who are maybe volunteering, who don't understand the language. And that was a really great piece of work and improvement for myself. Just everything that I've been involved in, had I not have got the experience that I did from all of this stuff, then I would have never reached the point where I am now of gaining employment, doing something that I'm really good at and that I absolutely love doing. I've always felt so well looked after and supported and encouraged, and the amount of opportunities that I've had to grow has been invaluable. Do you know what I mean? I wouldn't be here where I am now.
Slide, please. Thank you. So the Innovations is a new partnership. So innovations in the future of our partnership is we're focusing on trauma-informed, seamless journey for people who go through criminal justice. And the main sort of bit of work that we've done in the first sort of 4 or 5 months of the contract is we've worked on the single record system. We've adopted RIO, because it's AWP's record system. And we've worked really hard with the IT department and with business and information to bring together all our partners onto RIO. This helps so that our service users only tell their story once. As soon as they have contact with us, that story is told. But also it really improves outcomes with the information flow and with organisations doing safety plans and personal wellbeing plans. They're all on your team, your conversation, your plan. Said that the right way round. We actually had really positive feedback about that from one of our partners about how useful that process is and the system is. So that's really helping. It also has freed up clinicians, probably about 10 hours a week per clinician from filling in data sets. So NHS England's contract for integrated non-custodial services is very data heavy. Each service has about 189 fields of data they have to complete per service user. And with IT, huge amounts of work that has been done in the background, building specific parts of RIO we can now populate those data sets directly from Rio, which means clinicians aren't sitting there writing down people on a data set. Within our partners, we're developing interchangeable staffing profiles. That means you could be employed by AWP, but working within a DHI service or a Turning Point service, or vice versa, giving staff diversity, giving staff experience, and also helping with recruitment and retention. We've got joint management systems. We don't manage this contract alone. Everybody has the voice at the table. Although we are, in NHS England's eyes, the prime contractor, we run it as a partnership, and each partner has an equal say. And we're working collegiately with our other NHS trusts that are delivering integrated non-custodial services across the Southwest, linking up professional networks and ensuring best practice and eradicating the postcode lottery that you get sometimes for services. Next.
So in terms of prioritising the well-being of all our staff, really, you know, we're really proud of our lived experience element and bringing people through the volunteer scheme and into paid employment. Obviously, with that comes some additional support needs across the board. So we're really good at wrapping around those individuals as and when it's needed. You know, occasionally we may get it wrong and people do relapse, but we do our best to maintain everybody's well-being within the team. Obviously, the areas in which we work in are very challenging and difficult, and you're party to a lot of information that may cause stress. So we ensure that people receive regular supervision, you know, reflective practice, debriefs, you name it, those sorts of things. We've got the hub, we've got the college coming online as well. So hopefully between all those sorts of things, we can just keep improving the well-being of our workforce. And then obviously with that, the additional productivity that comes with that. And again, building on those networks with our other providers in the Southwest.
So in terms of developing our resources as part of an integrated service that's delivered in partnership with services with real kind of specialist knowledge about certain topics, we're fortunate enough to have access to a wide range of resources that we're going to continue to build and share, including resources around supporting peers. So I think an example from Ian is obviously, given my job title, is what I'm going to go straight to, but there's increasing recognition nationally that the needs of women are not always being met by criminal justice services. So I think having that kind of that partnership work allows us to develop our knowledge base and to develop our kind of pool of resources to really start kind of proactively meeting the needs of women and girls who find themselves in the criminal justice system.
Next slide, please. So we are incredibly lucky that NHS England have granted us every single year of the 7-year contract a development fund for both lots. So what do we do with that development fund? Well, we need to implement improvements and develop our services, obviously. And so we've got a system in place now that we're going to ask, and we're going to ask not just our staff, but we're going to ask the stakeholders, so the judiciary, the prisons, the courts, the police stations, everybody. And we're going to listen to what everybody has to say, including our service users are prime in that. And then we're going to act. So each year we'll have a development fund plan that will show exactly how we're going to spend it. Year one, which we're currently halfway through, was we actually commissioned a company to develop a level 2 accredited training in criminal justice neurodiversity. So it's specific to the environments we work in. What we were getting feedback from our service users and also from our staff was that the training that's available is fabulous, but you can't use a lot of it in a police station where there's no IT. You can't use a lot of those things. So to have one that's level 2 accredited that is specific to working in the criminal justice makes it real for our staff. And we have not only commissioned that and had it developed, but we also offer it to all our partners, police, probation, the judiciary. All our staff have been through it. We're all going to open it up then to the prisons as well, so that we know that there's a baseline of knowledge and an ability to make reasonable adjustments for people with neurodiverse needs. That's year one. Our service users will decide what year 2 is. Last slide. Thank you very much.
Thank you. Can I now invite Joe Cooper and Christian Bailey to share with us our third approach in relation to the 10-year plan, and that is the analog to digital work that we're going to be doing. Thank you.
Yes, thank you, Jan. Hello, everybody. You can probably read for yourself, but my name is Jo Cooper. I'm the Director of the Programme for Frontline Digitalisation. And
I'm Chris Bailey. I'm the Chief Nursing Information Officer of the organisation.
we're going to talk to you today about a couple of examples of analog to digital that we are doing at the moment at AWP. So just a little bit of introduction. In the last year or so, we've set up this programme for Frontline Digitalisation, of which I'm leading. This is the programme of change in AWP, digital change that affects our staff. So this isn't the back end servers, wires, pin stuff. This is the stuff that people touch and feel and experience every day. So we're hoping to make that experience better. That is our intention. I think I've covered that. So we're already doing that analog to digital. I think we're already on that path. So when the 10-year plan came out, we were really pleased to see that, emphasised. That's something we all agree with. So, there was no problems there. We were all happy to see that. Chris's role was created actually a little bit before the programme, wasn't it, as part of our EPR procurement? But it's really valuable in this programme. He brings a quick clinical voice in. He can challenge us. It makes us stop being too IT. It makes us think about the people at the other end who are going to experience our technology. So it's absolutely critical, and I think it's working really well. Very valuable post. And so we're going to talk to you today about two of our initiatives. That's electronic observations, which we're about to do next week, the week after next.
Week after next.
Yeah, week after next. And then a little bit further away, the Smart Notes ambient voice technology. So over to Chris for the observation.
Yeah, I'll talk about electronic observations. So the recording and taking of physical health observations is obviously a really important part of what we do, not just in inpatient services, but within our community services, although at the moment we are focusing on our inpatient teams. So we obviously use the News2 framework, which is a way of sort of recording and reporting and responding to a physically deteriorating patient. But that's all done on paper. We've been using Rio now for 13 years. Yeah, 15 years, but our physical health observation recording is still a very much paper-based process. And as you can imagine, that does cause some tensions. Our clinicians do it very well, obviously, but it's a number of issues, as you can see up here. The data isn't immediately in Rio because they're recording on bits of paper, News2 charts, which are on clipboards in people's offices. That data is to hand on the paper, but the trouble is to get it into Rio, there's a number of different forms that need to be filled out. We have to wait to the end of an admission or when a News2 chart is finished before they get uploaded onto Rio. There's a huge sort of industry, if you like, in terms of scanning and uploading documentation. The physical health data ends up in different parts of the Rio. We don't have any physical News2 charts currently within Rio itself. So the only way for a clinician who wanted to track over time someone's physical health journey would be to go to the ward, find the clipboard, pick that up and read what's on the clipboard. And obviously that's a challenge. If we've got doctors on call who are on different sites or different parts of the site, they need to have to attend the ward to do those reviews. There's a lot of duplication of effort. Our clinicians are recording on paper. They're then having to go at some point on their shift to record into the Rio record. And there's always a risk of transcription error or timeliness of the entry happening on our busy inpatient wards, as you can imagine. There's a number of challenges for them. Despite them doing as well as they can, we looked at this and thought there must be a better way. Digital must be able to help with this. So if you can go to the next slide, please. So where we are right now, and as Joe says, in 2 weeks' time, we're incredibly excited about this. We are launching a pilot at Hillview Lodge on the 2 wards there, one an older adults ward and one a acute admissions ward. And we are introducing the eOps package, and it's going to be focused on the News2 scoring at the moment. And what this allows our clinicians to do is to enter data on the recordings of their physical health monitoring they're doing for the patients and service users. They can enter it onto a tablet device where it's charted, automatically. There's no need for them to work out any scoring. And also, more importantly, it's going straight into the clinical record at the point of data entry. As I said, the application is calculating and use 2 scores. The clinical teams can then see that. So as I said, if you've got a junior doctor on out of hours who might need to attend to some of these physical health deterioration, they can see that on the record before they even get to the ward via Rio, which is really important. And, you know, for our clinicians who've been involved in this project, they're really excited because it's been co-produced with our clinical teams. We are really excited because we are the first trust in the country to be using this application. We're developing it with the Access Group, the suppliers of Rio, and so we're right at the forefront of this. Our clinical teams have been involved not just in the pilot project and setting the pilot project up, but they're actually co-designing and supporting the development of the app so it meets our exact needs, which is really exciting and a really nice place to be with technology. But you know, we're actually getting what we want and what we asked for. So yeah, we're starting the pilot on the 23rd, very soon. We're hoping, obviously, if that pilot is successful, that we would then look at rolling it out further on inpatient units. And maybe even in the community, we just heard about the importance of physical health observations for our community patients. This could actually help augment some of that provision in the community. And we're also hoping, you know, if this is successful, that it opens sort of the door for new innovations around mobile working. You know, our clinicians on the wards are already coming to us and saying, well, what about therapeutic ops? What about Section 17 leave management? What about all the other tasks we do every day on the ward that we need checklists and we need reminders for, and we need bits of paper and we need handovers for? What if we had apps that could support the, you know, the effective use of those things? So yeah, we're really excited. I think this is the start of a journey for us as an organisation, and it's been really, you know, exciting thing to be involved in with our clinical teams. So yeah, we'll hopefully in a few months' time we'll be able to tell you how it's going, and yeah, we'll be looking to the future.
You want to mention the toy?
Oh yeah, I have actually brought a toy with me. So if anybody is interested afterwards, I have got the app here. As usual, it's really hard to get it working on big screens and obviously with our remote view and see if it's not going to work. But if anybody wants to come have a sneaky peek after the session, I'll be more than happy to demo it to everybody.
Right, so we're moving on then to Smart Notes. Now this is a little bit further away, a little bit less formed. We're looking probably to do this early in the new year. Can we go back to the previous slide, please? Sorry, I realised I said Smart Notes, which is on the next slide. This is just sort of setting up the current situation. At the moment, we have obviously many community staff going out and having appointments with service users. They will go to their homes or to designated destinations, and they will have a conversation, a rich conversation, a clinical conversation, during which they will take notes. And then at the moment, they have to go away and they have to write that up. They might take paper notes, they might take notes on laptops, but that's a sort of barrier while they're having that conversation. They're having to look up, look down, think, how am I summarising this? What am I capturing? They go away and they have to write it up. And similar to how Chris described with the EOBs on the ward, the observations having to make it into the record, our community staff have that same challenge. They have to go away, they have to find time in their day to sit at the computer. And at that point, they then have to recall, and they might have seen 4 or 5 people in that time. And they're like, I think it was that person. Obviously, we trust everyone, but you know, there's recall, there's accuracy, and there's timing, there's challenges to the fact that that doesn't go in straight away. So I think I've covered everything on that. So next slide, please. So this is where Smart Notes comes in. Now, this is using ambient voice technology. This is an AI-driven piece, sort of technology that's coming along now, which will listen to conversations. It will use natural language processing to summarise that conversation and then make that available back to the clinician. So in a sort of example of what could happen, the clinician could sit down with the service user. They could have that conversation like they do before, but they can, as long as they've consented them, they can leave their smartphone to one side, listening to the conversation, and they can focus entirely on the conversation that they're having at that time. At the end of it, the software will summarise the conversation for the clinician and the service user in a co-productive way to talk through, does this represent what we talked about? Do we think we've captured everything? And if they're happy, they press a button. They can amend it, obviously, but if they're happy, they press a button and it goes straight back into Rio.
again, instantaneously, providing there's a network connection, it will do it as soon as there is one. So that need to do it later, that need to remember, that need to find time in the day to sit down and do it will be gone if it all goes well. So we've procured the ability to do a pilot for this. Now, this Smart Notes is the product that Access Group offer as part of Rio, which is why we've got that integration back to Rio, which is pretty valuable. But we want to see how well this actually works. So this is using AI. We all hear a lot about AI. There's a lot of nervousness, there's a lot of anxiousness, and I think we want to take this carefully and make sure we get it right. So we need to look at this. We need to see if what it's coming up with is correct. We need to make sure people don't just go, yeah, fine, every time. You know, people need to be able to look and check that this information is accurate. So we're going to go carefully with it, but we hope to get this going in the new year. We have a pilot team agreed at South Gloss Early Intervention team. They're very keen. They're going to help us develop it. So we're on the same journey as we are for EOS. We're just a little earlier in it, but that's coming in the new year. Yeah, the last point was just that in time, again, this will offer more opportunities as the software is going to be developed to generate letters and follow-up appointments and that sort of thing, but it's just not there yet. So we're going to push the Access Group to develop what we want to see in it. But rather than wait for them to develop it, we're going to ask them to develop what we think we need.
It's really a seat at the table, isn't it?
Yeah, absolutely. So I think that's all we had today. Bit of a whistle-stop tour. The next one we had, yeah, questions, but obviously I appreciate your holding those for the end, Jan. So yeah, thank you very much. No problem. Thank you.
To invite, first of all, thank all of the speakers. Did really well. Thank you very much. It was really informative. I'm going to invite questions. Are there any questions? Are there any questions from the public, Donna, before?
We haven't received any submitted in advance.
Okay, thank you. Any questions in the room?
Hi, I'm Amy Nettis, I'm the Chief Executive of FEP. Yeah, fantastic presentations and things like that. One thing I was particularly interested in, and once again, congratulations to really focus on your EDI work that you're doing. It's so important for all of us, and especially for underserved communities or people who are overtreated in the mental health system. You mentioned that the board had made a pledge, and I was kind of interested to know what that pledge was and any learning and reflections from board members on how that's going.
So which one to?
Yeah, I'll start with that. So yeah, thank you, Amy. And as you say, incredibly important for the wide range of communities that we serve in what is a huge geographical area for AWP. So in terms of the pledges, it's a series of pledges that have been led by the Chief Executive. So there isn't an overall pledge that I can stick on a slide for you. It's a number of pledges. But certainly just as a reflection within the board. So we've had a couple of board seminars that are specifically related to our EDI work. And as I said earlier, hosted by the chairs of our groups. So we have a number of different groups, different staff groups within the organisation that represent different characteristics that are important to our staff members. So they have come in and spoken at board and worked with the board, including some quite challenging questions and conversations, I would reflect. And then as well as that, which is really key to what you say, is our work with the Patient Carer Race Equality Framework. So we have a group that is run centrally, that I am the sponsor for, but as well as that, as part of one of the areas is about reaching those diverse communities. And so, for example, there's a lot of work happening in BSW with some traveller communities, which are a group of people that would not normally be served at all. So we're trying to look at different things in different areas accordingly. And then drawing that together as well, I have another board session, a board seminar. So there are regular touch points with the board moving forward. There's a lot of work going on in that area, and I know that our work in partnership with organisations like yourself is really also key to that, because some some groups do not trust our services, quite understandably so. So actually having those community links to make those introductions, it's so important. And then one of the other areas that we're specifically looking at, I'm looking to Paul because he chairs that committee, is the Mental Health Legislation Committee. And that is an area where we're really starting to challenge ourselves to look at the differential use of mental health legislation in different groups.
Yeah. And do you want to add a little bit about we as board members and the reciprocal mentoring scheme?
Oh yes, yeah. So there's a lot in that space. So we have a trust-wide reciprocal mentoring program, but that it was started with board members. So I think all of the board have gone through that now, where we have links with people within our staff, so that we have one-to-one reciprocal mentoring, and that's been incredibly valuable, and it was such a success that I think we're now on to our third tranche of that. So moving forward, there's a lot of work in that space, but we can never say it's done. We've always got to continue to build and to move forward. So thank you for your questions. Really, thank you. Helpful.
Any other questions, Paul? Paul on screen.
It's more of an observation than a specific question, but I would be delighted if people could just respond to a bit of it. What I've been really taken by all the presentations is the importance of involving service users, carers, stakeholders and staff in helping us to identify and improve. And that's come sort of loud and clear through, as I said, all the presentations. So for the three groups that presented, what could we do more to spread your excellent work to other parts of AWP? Because we're a very large organisation, and if you're beacons of excellence, how can we share your excellence with others?
I would say, Paul, I'm not sure from a lived experience perspective how much of beacons we are, or whether we actually represent how the organisation works around this. Having worked across a number of different types of NHS trusts, I think mental health trusts and AWP particularly are really committed to lived experience voice in terms of improvement and change compared to many other sort of parts of the sector. So I think actually we probably represent generally the approach that we want. I think there's probably, we love sharing our successes and learning at these forums as well. And we do have other opportunities to do that, things like our leadership forum as well. And we're doing quite a lot of work with our sort of communications colleagues who are in the room as well to make sure that we've got opportunities for staff to hear about what we're doing. So I think there's a lot, like the EDI stuff, there's a lot of stuff already that we're doing and sharing, and always more to do. But I think it is really embedded in terms of the improvement, quality improvement approaches that we have within the trust.
Thanks, Sam.
Yeah, I was actually interested in the presentation that you guys did, and you talked about how getting a co-production, and I went, don't know what that is. That sounds really interesting. So I'm kind of interested to find out more about that and whether that falls in any way from that.
So that was launched last year by NHS England, nationally, and it's actually part of the requirement for integrated non-custodial services contract award that you either have it or you work towards getting that gold standard. We were a year ahead of everybody else. We already had our gold standard for that charter, but it's not something that you've got and you sit back on. It's something that you've got to work every single year to prove to NHS England that you are continuing to develop that. It's not just like we've done it, we include our service users. How are we developing that and moving it forward all the time? And being co-produced, it has to be not just a tick box, it has to be real. So we are constantly striving to have people who are still in prison. I spend a lot of time signing my life away getting people out on temporary license. I've also with the police and with the courts on getting people through security clearances and all sorts of other things. But to ensure that our stakeholders take that lived experience seriously as well, and that they have that co-production, because we can be a health service over here doing trauma-informed co-produced work. But if you're working within an organisation that isn't trauma-informed and isn't co-produced, then it's just a tick box. So we're striving to get people into all aspects of that. And sometimes with the judiciary, that's a little hard. And we love all that IT innovation that you come up with, but we're not allowed mobile phones.
Oh,
yes.
Elle, did you want to add to that?
Yeah. I mean, I think something that I would just like to reflect on is a piece of work that I've been doing in collaboration with Sam and Kelly, who you heard from, focusing specifically around women's pathways in the women's custodial estate. But something that's come through loud and clear from the women that we've spoken to is the importance of not just kind of the question being asked, but also them being involved in an ongoing process where, I mean, we all know that things in terms of like kind of strategy and development, things take a long time. But a lot of women have had the experience in the past of people coming in with a clipboard, asking a load of questions, a load of really quite personal, quite emotive questions, and then disappearing off into the sunset with no idea of what was ever done with that information, if anything. So I think what's really come through as a priority is to just make sure that people feel valued, make sure that they know what's happening with their contributions, even if it's a case that we are aware, this has been fed back, this is informing our decisions, but it'll be a while before you notice any change kind of on the ground.
Thank you. I think that's really critical. I've got 3 more. I'm going to go with Barry.
Hi, so my daughter is Lucy, and she died at the Riverside Hospital last year. It's now been close to 20 months. You know that patients closer to home generally do better. What is the plan for reopening or replacing the Riverside unit?
I'll take that. Yeah, thank you for that question. It's really important, and it's something that we focus on a lot. We are committed to having inpatient beds in our geography. We absolutely are. We recognise that in an area such as ours, we need to have those beds. But on the other hand, we also want to ensure that we produce as safe and as good a service as we can. There have been a number of issues with the estate, with the building of Riverside in and of itself. And we're exploring what we can do for the best in the medium to long term. So that's why there have been delays, because it hasn't been a question of working with the team and then reopening in the same way. We've got a number of issues with that, so we haven't been able to do that as yet. And we are still exploring all of the options to get beds back into our area.
When would you think you would be able to have an available hospital that is local to the population?
Oh, no, I don't know the time. We haven't got the timescale as yet. We're still exploring, aren't we?
It's a very, very complex area.
Yeah.
And there are lots of guidance that we have to follow in terms of national standards around these particular units. I think probably what will happen over the next few months is that we will complete our options appraisal, and then we will then at least be able to cost up what those models look like, and then it will be a system-based conversation about how would we effectively release the funding or the services that are available to make effectively that new environment, as Sarah said, as safe as we possibly can. So we're committed to doing the options appraisal, getting that effectively into the format that we can make to get a system-based decision.
Thank you for the question.
Can I just add something to that? Okay, just very briefly, thank you for the question, Barry, and it is so key. I suppose to add to the longer, medium to longer term stakes question, we are also working with our Commission Service providing collaborating to see what we can do in the interim, the inpatient bedding footprint, and we've got some proposals that we're hopefully going to apply in the next few months, and much sooner rather than longer term stakes.
No, thank you.
Okay, thank you for the question. I am conscious of time. Are there any other
questions, any other burning questions? No? Okay, I am then going to draw this AGM to a close. First of all, I'd like to say, in summary, where we've been, we've taken a retrospective look at the services and how we did last year in relation to our strategic overview, our financial performance, and then an aspect from the quality account. And then the presentations gave us our perspective overview, where we are going in the future in relation to implementing and embedding the 10-year plan. And I think what we heard was that move to hospital, from hospital to community, as well as treatment to prevention. Those two areas, we certainly heard about the partnership working that we are implementing, embedding within the organisation, the partnerships with VSCs and BSW, and also partnerships in relation to the non-custodial criminal justice services. And it is important for us to recognise that we can only, if we wish to deliver our vision and the vision that we have of the organisation, to provide that compassionate care to service users and their wider stakeholders, their families, then we have to continue to work in partnership to move forward. We have a lot still to do. So we've had some really celebratory information this morning, but we have a lot to do. We know we have a lot to do in relation to the CQC, but also to continue to strengthen the services in partnership and engaging in collaboration with our stakeholders, our service users, their families, their carers, to deliver the best quality and the safest care that we can. It is a journey and we continue on that journey. But for today, what I'd like to do is to take this opportunity to thank all of those that came along to present, to thank the staff, the service users, people that co-produce with us to do the best that we can do, or to try to do the best that we can do, but for us to continue to do that. So I'd like to thank you. I'd like to thank you, Barry, for actually coming along and joining us today. And with that, I'd like to draw this meeting to a close. Thank you very much.